Good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19, infection control, and other nursing home related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communication specialist with Quality Insights. Today's webinar is Sepsis in Long-Term Care, an Overview. This is part one of a two-part series. We invite everyone to join us next Wednesday for part two, which will be case scenarios of sepsis in long-term care. If you're interested in joining, that will be the same time and place next Wednesday at 2 p.m. And now I'd like to introduce our guest today, Emily Magee. Emily is an experienced infection preventionist with a passion for ensuring patient safety through education and collaboration. She has a background working with specialized patient populations, including burn, transplant, behavioral health, and labor and delivery. She has worked in various healthcare settings, including large academic medical settings, community hospitals, ambulatory surgery centers, and long-term care facilities. Her most recent role has been as the infection prevention supervisor for Pennsylvania Project Firstline, an innovative project by the Centers for Disease Control and Prevention to provide free education to frontline healthcare workers. Emily loves that infection prevention is continually changing because it allows her to do what she loves most, find new solutions to problems that support our frontline healthcare workers and patients. Emily, welcome, and thank you for joining us today.
Thank you. All right. So as was already shared, my name's Emily Magee, and I supervise the Project Firstline program. As was already addressed a little, Project Firstline, if you're unfamiliar with it, is a really fun program that is a partnership between state jurisdictions and the Centers for Disease Control, or CDC, in which we provide free infection prevention training to frontline healthcare workers. This includes all frontline healthcare workers in any healthcare setting. Again, this program is offered across all 50 states. And it grew out of a response to COVID-19, in which it became clear that facilities were struggling with that basic infection prevention education and training. So information will cover topics like hand hygiene, cleaning and disinfection, source control, PPE, et cetera. And it, again, is really to strengthen our workforce, because we know that infection prevention is key in public health and keeping our community safe. As I said, each jurisdiction has a Project Firstline team, and actually in Pennsylvania, we have two Project Firstline teams. The PA Project Firstline team, which is part of the state and oversees all jurisdictions except for Philadelphia. Philadelphia actually has their own Project Firstline due to the size of that city, but we do partner with Philadelphia Project Firstline, have routine calls with them. So a lot of the work we do builds with the work of the Philadelphia team. But as you can see, the PA team consists of 6 IPs, and I do like to highlight that they're all certified in infection prevention. And our team is comprised of 2 general IPs, Ariel and Purva. They manage our most of our remote virtual programs and program development. And then we have Mary, Kelly, and Carolyn, who are our travel IPs. Carolyn actually will be here next week to conduct part 2 of the case scenarios for sepsis. So after this, the end of this presentation, we're hoping that participants will be able to identify at least 3 signs and symptoms of sepsis in long-term care residents, describe 3 or more interventions for sepsis surveillance and treatment, demonstrate understanding of at least 4 best practices for early detection and prevention of sepsis, and apply 3 or more sepsis prevention and control strategies to their unique long-term care environment. But before we jump right into what sepsis is, I like to ask everybody to just take a moment and think about long-term care and what those settings really look like to you. We know that long-term care settings, while lumped together, can take on a number of different looks. So we can have intermediate care, personal care, skilled nursing, acute care, subacute, assisted and independent living. And these are all, while unique, forms of care that fall under the long-term care setting. So as we're going through what sepsis is and how to prevent it, think about your facility, your setting, and how these rules of prevention can be applied in those settings. So now we're into the good stuff. What is sepsis? And this is, if you can take away one thing, I hope that you take away that sepsis itself is not an infection. Sepsis is our body's response to an infection. So it is a life-threatening response to an underlying infection. These infections can be in the lungs, urinary tract, GI tract. They're usually bacterial, but they can be viral, fungal, parasitic, just like any other infection type. So because this is our body's almost an over immune response to an infection, it can quickly cause tissue damage, organ failure, and death. It's important to remember that sepsis is not contagious, and it is not blood poisoning. That term gets used sometimes for sepsis, but again, we really want to make sure that we're differentiating that sepsis is our body's response to an infection that can originate from anywhere. If we had a bloodstream infection, for example, we would call that a bloodstream infection, or if it was central line associated, it would be a CLABSI, but sepsis is unique to that. It's not the same as blood poisoning, quote unquote. And of course, some of the risk factor, our population of residents does typically make them at greater risk for sepsis, as it makes them at greater risk for infection. So the risk factors for sepsis include age, either end of the spectrum, very young or older, chronic health conditions, compromised immune systems, pregnancy. Unfortunately, prior history of sepsis is a risk factor for sepsis in the future. So if you've survived sepsis once, which we'll talk through, you are at a greater likelihood of developing it again. And if you've had recent severe illness or hospitalization. And again, when we think about these risk factors in terms of the resident population that we serve, oftentimes individuals are coming to us post-hospitalization. So they are inherently at greater risk for sepsis. Some of the key statistics, incidence, which is the number of new cases identified when we're thinking about epidemiology. About 87% of new sepsis cases occur in the community as opposed to the hospital. That is a huge proportion, and that's why we're going to talk through some of the signs and symptoms and actions that we can take, because they're not often seen or presenting in the hospital. The prevalence or amount of the burden of disease in a typical year, about 2 million American adults suffer from sepsis. It greatly increases healthcare costs. The average cost per hospital admission due to sepsis about doubles the cost of other conditions. And unfortunately, mortality is increased with sepsis. About 350,000 patients die with sepsis during hospitalization or are discharged to hospice. So the severity is clear. Now, as we stated, sepsis is our body's reaction to an infection. So unsurprisingly, a lot of the signs and symptoms that we see with sepsis look similar to what we would see in an infection. So we may have tachycardia or a weakened pulse, hypotension or low blood pressure. And this is a little unique in sepsis because we'll identify hypotension and then you'll see the hypotension will continue to get worse. Altered mental status is one of the key markers of sepsis. Fever or hypothermia, diaphoresis, hemorrhagic rash, dyspnea, or shortness or difficulty breathing. Either of any of these conditions are signs and symptoms of sepsis. So if we see these together, we want to be thinking this resident may have sepsis. And if you suspect sepsis, similar to the stroke FAST acronym, response in sepsis, time is of the essence. So the Sepsis Alliance has created this acronym for us to remember if it helps for identifying sepsis in a timely fashion. So the acronym is TIME, and that stands for temperature, which we've already discussed. High or low temperature can be a sign of sepsis. Infection, so if we know that the individual has an ongoing infection. mental decline for the M, and if they're extremely ill. So if they're in pain, discomfort, shortness of breath, those other symptoms that we reviewed. I was trying to see if it would, okay, on this slide, if they're extremely ill, we want to consider sepsis. And if you experience a combination of these symptoms, you want to ask yourself, could it be sepsis, and call for help. So call 911 for an intervention. So if we suspect sepsis, the first and most important thing that we're going to do is assess the resident. And this is, again, I know we stated that about 90% of cases occur in the community, but now we're talking if you're within your facility, for example, and you're interacting with a resident. So the first thing that you would do is a detailed assessment of the resident, look at vital signs, symptoms, perfusion status, and determine their responsiveness or level of consciousness. Immediately activate 911. So if you are concerned with sepsis, you want to make sure that you remain with the resident, call EMS, and state to them very clearly, I am concerned about sepsis. Prepare the resident for transport. Make sure you're maintaining their safety, comfort, and privacy, and monitoring them and ensure that their airway is working. And then we're going to work with EMS to transfer to an acute care hospital, because as we'll see, their treatments are going to require the level of acute care. So we'll talk through that, but you'll provide an inter-facility transfer report, ideally using the SBAR, just like anytime we communicate with our EMS providers during a transfer. You want to provide the situation, background, assessment, and recommendation that you have for the resident. And if possible or helpful, use a transfer tool. And I should note, these slides will be shared if they haven't already, and the links will work. So if you want an example of a transfer tool, it's available for you in the slides. All right, so we know what sepsis is, we know what we're looking for. It's important to note that there are different stages of sepsis. We use an all-encompassing term of sepsis in general, but there are 3 distinct phases of sepsis. Stage 1 is that initial sepsis. It's that overaction of the immune response to an infection. And while it's stage 1, it's already life-threatening at this point. Stage 2 is where we enter severe sepsis. We'll start to see that lowering of blood pressure and inflammation throughout the body as that blood pressure lowers, and we may start to experience organ and tissue damage. Unfortunately, in some cases, it does progress into requiring amputation. And then stage 3, and this is what we think of with septic shock. So the patient's been transferred to acute care. They've been getting IV fluids and other medications that they may need. We've done everything, but they're still experiencing organ failure, and death may still occur at this point. So basically, they're non-responsive to treatment, the sepsis has evolved past to stage 3, which is that shock. So as we said, you do a physical assessment of the patient, but we can also do confirmatory testing depending on the facility. When we're looking for confirmatory testing using biological markers, we may look for an inflammatory response within the body. So looking for white blood cell count. We can monitor the hemodynamic status of the patient, organ dysfunction, measuring things like urine output, coagulation, bilirubin, et cetera. And we can measure tissue perfusion. And this is, I was looking through the slides to make sure we have this. So early detection is critical to initiating that rapid response. So we recognize the symptoms, we're initiating a response, but I did, studies show that the risk of death, increases by an average of 7.6% per hour prior to treatment. So every hour we wait, not necessarily wait, but every hour that diagnosis and treatment is delayed, the risk of death increases by 7.6%. So the treatment, we generally will always have IV treatment. That includes IV fluids and IV medications. IV fluids are Generally, you're going to see that in sepsis response. IV medications are going to be dependent upon, like if they know the source of the sepsis, for example, if we know that it's a bacterial infection, we'll implement broad spectrum antibiotics, for example. So the IV medications are generally more tailored to the infection type that we know, but that fluid treatment is critical for sepsis treatment. Because sepsis is life-threatening and can have such severe complications, depending upon the stage and the individual, in addition to IV fluids, other treatment may be needed, including the insertion of a tube for tube feeding. Patients may need to be intubated, which we know each time we introduce a device into a patient or resident, that increases their risk of infection. They may require oxygen therapy, dialysis. In some circumstances, they'll even need intracranial pressure monitoring, or either urinary or other catheterization. So they may need, obviously, peripheral lines for IV fluids, but they may need central lines as well, depending upon the situation. And let's say that the individual or resident is able to survive sepsis. So they are one of the individuals that survives sepsis. There's what's called post-sepsis syndrome, or PSS. And post-sepsis syndrome can be very impactful for the resident. They may experience things like muscle and joint pain, swelling and skin rashes, insomnia, hair loss, poor appetite. I won't read all of them, but it's just important to note that upon survival of sepsis, there is this post-sepsis syndrome that some individuals will develop that can still have really devastating effects for the resident. And one thing that people may not think of is they have noticed post-traumatic stress disorder in residents who have survived sepsis. And if you think about it, it can be a very traumatic event for a survivor. The rapid deterioration, transfer of care, increased interventions, and that just the scare of it all can really, it's been shown, people have been shown to have post-traumatic stress disorder following sepsis. So not only do we have the physical burden, but then we have the psychological burden as well for individuals that survive. Now, we know what it is, we know how to recognize, but how are we going to prevent sepsis from occurring? Ultimately, we prevent sepsis by preventing infections. And we always say on Project Firstline, IPC is a team sport. There is no one individual who can oversee, who can be responsible for the entire infection success of a facility or a program. Everybody that enters your facility at any given time is an infection preventionist by performing hand hygiene, utilizing source control, vaccinating. Those are all things that we all do on a regular basis to prevent the spread of infections. And we use all of those to prevent sepsis. So while this, I'm sure, is not new information, we do like to stress that hand hygiene is one of the most effective thing that we can do to prevent infections. If we perform hand hygiene at the right time in the right way, we prevent up to 50% of healthcare-acquired infections, according to the CDC, and it's so simple and effective. So a few things that we like to stress is you want to make sure that you are performing hand hygiene before clean or aseptic procedures. That includes preparing meds and food, before resident contact, before donning PPE, and then of course after donning PPE, after contact with the resident or their environment, or after body fluid exposure risk. And I wouldn't be doing my due diligence if I didn't say gloves do not replace the need for hand hygiene. Putting on gloves does not equal hand hygiene. When you take off your gloves, you want to make sure you're cleaning your hands. And again, you want to perform hand hygiene prior to putting on gloves to protect the gloves and to limit the germs on your hands from spreading. So in addition, as we were talking about gloves, you want to make sure that you're donning and doffing personal protective equipment, or PPE, for the specific activity or care that you're providing. So you're going to wear a gown that's appropriate to the task. So if you're doing something that's going to have a lot of potential for splashing, hopefully you'd have an impervious gown. If you're doing something like isolation, you're going into a contact precautions room, an isolation gown. But essentially the gown is appropriate to the task to protect the skin and prevent soiling of clothes so that you're not then going from resident to resident transmitting germs. You're going to put on gloves when it can be reasonably anticipated that there could be contact with blood, body fluid, or non-intact skin. So if you're going to be doing a skin assessment or you're doing an assessment of the patient and you notice a rash, you want to make sure that you are gloving prior to having contact with the rash. That prevents things like scabies. And then obviously masks. So you want to use a mask or protective eyewear or face shield to protect that T-zone, the mucous membranes of the eyes, nose, and mouth from splashes and sprays. So any activity that could generate splashes and sprays, you want to make sure that you're taking precautions to protect your eyes, mouth, etc. And I always, sorry, I'll get back to PPE. So PPE is what we put on. It's personal protective equipment. We put that on to protect ourselves from germs that the resident or patient may have, to prevent the spread to us and to prevent the spread to other individuals. We also have this concept that everybody became familiar with through COVID-19 of source control. And source control stops germs from spreading by stopping them at their source. So that can be, we often think of masks, which we'll talk about, but source control can also be bandaging a wound. So when you're covering that wound, not only are you protecting it from not only are you protecting germs from getting in, if they're you're protecting germs from getting out. So if there was an infection, for example, bandaging it can limit the germs from spreading from that source to the next individual. Obviously, source control that we experienced through COVID-19 precautions, covering the nose and mouth with a properly fitted mask. And that, again, if the individual is sick, or maybe they're sick and they don't know it, that prevents the germs from spreading from their nasal passage or mouth to other individuals. And then again, with covering, similar to bandaging a wound, you can cover a rash. So oftentimes, for example, with shingles, if it's limited to a dermatome and we can cover the rash, there's little risk of spreading the chickenpox virus through that just by covering the rash. So there's different ways to look at source control, but they're all important in preventing spread of infections and preventing sepsis. And so now that we've talked about source control a little, it is important when we're thinking through wound care in particular. As we stated, sepsis can occur from a skin infection. And so we want to make sure through wound care that we're assessing, cleaning, and dressing for success. So you want to gather and dedicate supplies before a dressing change to prevent contamination. Perform hand hygiene before preparing a clean or sterile field and before starting wound care. Don fresh gloves and PPE, depending upon the wound or the procedure. You may require a mask during the procedure. You can position barriers under the wound and clean wounds using aseptic non-touch technique. Now, again, with wound care, a few things to remember. You want to remove and discard old dressings as well as soiled gloves in the appropriate receptacle. When you have discarded and removed of those gloves, it's important that you perform hand hygiene and don new gloves to access supplies. Otherwise, you're just contaminating the clean, fresh supplies, potentially contaminating. You want to clean and disinfect reusable equipment as well as the wound supply cart when you're done, and repeat doffing and hand hygiene procedures as needed as they come up through the care of the resident. Another core action that we can take to prevent infections and therefore sepsis is through environmental cleaning and disinfection. There is a difference. We lump cleaning and disinfection together because we expect both practices to happen within healthcare, but cleaning is the removal of soiling like dust, dirt, grime, spills, blood, etc., from the surface. So you see dirt, you wipe it. That is cleaning. It may remove some of the germs. In comparison, disinfection has to kill a certain amount of germs, and it's done in a certain way. You meet the contact time on the disinfectant, which tells you how long the surface needs to be wet. And that ensures that we have removed germs after cleaning. So you do environmental disinfection after you have cleaned the environment. So it's really a two-step approach. And obviously, immunization is a key way to prevent infections. We want to promote vaccines over natural immunity. Natural immunity obviously can occur, but we want to, and whenever possible, if there is a vaccine for a preventable disease, we promote the vaccine because we know risk to the residents lower. There's often inactivated vaccines that aren't going to cause any harm. It's just an immune response. So we want to encourage vaccination over natural immunity as much as possible. We want our residents to stay up to date with all vaccinations. And obviously, an important component to vaccination is ensuring proper storage and handling. So make sure that vaccines are stored at the right time or at the right temperature, whether it's freezer or fridge. Monitor the temp to make sure you're staying within range. If you are using a multi-dose vial for your vaccines, there are very specific steps that you are to follow to prevent contamination of the multi-dose vial. And we do have information available on that through Project Firstline if you're interested. And then obviously you want to make sure that you're following sharp safety and needle stick prevention. All right, now testing for underlying infections. There's various types of tests that we do on a routine basis, depending upon the facility. You can test blood through a blood culture, do urinalysis. We can do radiographic and imaging tests or confirmatory and diagnostic tests that we've hinted to a little bit previously. But essentially, this is telling us that we need to make sure that we're testing for these underlying infections. If we test for the underlying infections and start appropriate treatment, depending upon the infection, we can prevent sepsis. And one component of that may be a challenge for long-term care facilities is that if you want to be ready to test in long-term care facilities, there's a few different ways to do it. A lot of hospital or health systems will provide lab partnerships with our skilled nursing facilities and long-term care facilities throughout the state. We also have community-based laboratory vendors, and you can do various in-house point of care testing, again, depending upon your facility. If you're doing point of care testing, obviously you have to have the QIO waiver. And if you want more information on how to do a QIO waiver, we do have the Bureau of Labs with the Pennsylvania Department of Health and the Long-Term Care RISE program that can assist with point of care testing and QIO inquiries. So we want to, if we have tested for an infection and we are aware of the infection type, we want to correctly diagnose and treat. Obviously, antibiotics should only be used for bacterial infections, antivirals for virals, et cetera, et cetera. All right, and then from a therapeutic standpoint, we want to recognize antimicrobial resistance. This is when essentially a bacteria has become, or microorganism has become resistant to antimicrobials that we've typically used to treat them. We primarily see resistance in antibacterials and antifungals. And you have experienced this through multi-drug resistant organisms such as MRSA, VRE, CRE, et cetera. But it's important to note that we're using the right antibiotic for the right infection at the right time to prevent increasing antimicrobial resistance. And then from a risk management standpoint, we know that there are key places within the body and the environment germs can live and grow. So within the body, germs often live on sources that can cause sepsis, that we can get infections in that lead to sepsis. So skin, GI system, respiratory system, or blood. Germs can also live in the environment on water and wet surfaces, dry surfaces, dirt and dust, and devices. But through all of the prevention efforts that we've talked through, we can limit the germ spread from the reservoirs to residents. And that's all I have for part one. Did we have any questions?
All right, thank you, Emily.
Mhm.
We don't have any questions so far. If anybody does have a question, please submit it using either the chat or the Q&A tool, or you could raise your hand if you'd like to ask your question out loud. And while we're waiting, I'd again like to invite everybody to next week's webinar, which will be discussing case scenarios for sepsis in long-term care. We also invite everyone to, if they want to join our live chats every Tuesday and Thursday at noon if you have more questions. One of our quality improvement specialists will be there to answer your questions on topics such as quality improvement initiatives, infection control, or MDS coding. You can find the links to the live chats and our webinars in the newsletter we send out each Friday called the Last Minute Lowdown. And if you'd like to receive that newsletter but don't think you're on our mailing list, you can email me at caudill@qualityinsights.org, and I will drop my email in the chat right now if anybody needs that. And I don't see any questions.
Great.
So Emily, do you have anything you'd like to add before we wrap up?
Nope. I'm excited. I hope everybody can join next week. We'll be able to build on some of these topics with case scenarios. So this was the information that you'll need to be able to answer the questions next week. So
All right, thank you.
thank
And
you.
I also, you mentioned earlier, I did put the link in the chat for the presentation slides.
Great. Thank you.
All right, so I will go ahead and wrap us up then. Here we go. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Emily, I'd like to thank you for joining us and for this presentation. And I'd like to thank all of you for joining us and hope to see you back here again next week.